So this is the second lecture on drug and addiction. It goes over some of the material we learned from the first lecture, but with a little bit more detail and examples. Last lecture was a little long. So there's lots of different types of drugs. Not all drugs have the same level of addictive characteristics, and some aren't as harmful as others. Heroin is highly addictive and highly harmful. But we're going to take a look at a few of the other drugs and a little bit more about the incentive sensitization theory of drug addiction. Well, these are just some of the areas that get involved in the action of drug addiction. We've talked about the nucleus accumbens, and here we are down in the brainstem, the substantia nigra, and the ventral tegmental area, but other areas like the prefrontal cortex and the amygdala also play a role. So let's look at a few types of drugs. Cocaine is a potent dopamine agonist. It helps dopamine. An antagonist stops the function of a drug or its actions, and an agonist helps it in some way. So cocaine is a direct dopamine agonist, and we talked about how addictive drugs, one way or another, increase dopamine activity in the nucleus accumbens. This binds to presynaptic receptors and blocks them, blocks reuptake of dopamine, and so more dopamine is in the synapse and more dopamine affects the postsynaptic cell, and thereby increasing dopamine activity. There's a lot of ways of looking at cocaine's effect. We can look at it physiologically and we can look at it behaviorally. One example is that a rat will press a lever to get cocaine injected into, for example, its jugular or directly infused into the nucleus accumbens. So oftentimes we look at drug addiction and the strength of the potential for that drug to be addictive to the level that the animal will self-administer. So let's go and watch this video, and it shows a little bit about how cocaine works. So here are the different types of images in this image here. The red is cocaine. Up here this is the presynaptic area. This is the postsynaptic. Yellow is the dopamine. You can see that dopamine is released and is affecting the receptors, but it can't go back up the presynaptic. Dopamine and then cocaine blocks the reuptake transports, and then dopamine can't get back up. So that increases dopamine level in the postsynaptic cell. Increased dopamine, increased motivation, and we have an addictive problem. So we know that cocaine is a positive reinforcer. Now, what's interesting about cocaine is people take cocaine. There is a pleasurable effect to it, but it isn't the main motivating factor here. Cocaine is affecting the mesotelencephalic dopamine system. Part of that system is the nucleus accumbens. Animals will self-inject dopamine into that area, lesion the nucleus accumbens, and there isn't that self-administration paradigm. But you can't go and lesion people who have addiction problems because this is the motivation center of the brain. Some people call this the do-it-again center. I've literally read that in journal articles. The do-it-again center. Whatever you just did that made dopamine activity increase in the nucleus accumbens, do that again. It's the motivation center and not the pleasure center of the brain. That's a very important distinction. We also know that people who stop taking cocaine or crack cocaine will show cocaine withdrawals, which is a reduction in the nucleus accumbens activity, and we also get a decrease in motivation. Here are just some examples from experiments that I was looking at. This is measuring the dopamine concentration in the nucleus accumbens when somebody administers cocaine. You can see the dopamine level activity go up, stays up for several hours, then comes down. But it's also true for amphetamines. Amphetamines also are dopamine agonists. not in the same way cocaine is, but they are dopamine agonists. You can see amphetamine increases dopamine activity. That's why cocaine and amphetamine and methamphetamine, these are very addictive drugs. So there's the dopamine concentration, and there's the time that it's administered. But nicotine does this as well. This is a control group that just gets saline, again measuring dopamine percent increase from baseline, and this is the time that people get nicotine. Increases dopamine level activity, it drops down, people take another cigarette, more nicotine, and it goes up. You know, the cigarette companies for a long time were saying that cigarettes weren't addictive, but they had been working very hard on changing the way the nicotine in cigarettes was getting to the nucleus accumbens. They were adding chemicals to it, what are called chemical vehicles that get nicotine to that area more quickly. Cigarettes are terribly addictive, and it's not that they're pleasurable, it's that they're motivating. Get away from the notion that motivation is always a good thing. Opiates are going to increase dopamine, but they're going to do it through a second system. It's a little bit more complicated than cocaine. Opiates bind to opiate receptors. This activation decreases another neurotransmitter activity known as GABA. GABA normally inhibits dopamine, so dopamine release is increased. Opiates affect other areas of the brain, but it decreases GABA, which increases dopamine, because GABA normally is acting as an inhibitor to dopamine. Inhibit the inhibitor. That's how it works. And this is just a cool image I found online showing opiate receptors. Now, naltrexone blocks the effect of opiates. It is an opiate antagonist. It's an opiate antagonist. It's very important. All medical personnel keep a syringe of naltrexone with them, especially out in the field. Somebody overdoses on opiates, they inject this, it blocks those opiates from binding to the receptors, and people can actually come out of this overdose relatively quickly. But it can also reduce addictive properties of heroin, but it can also reduce the addictive properties of cocaine and even alcohol. So let's go back to this notion about the difference between a drug's physiological effect. People or animals that take these drugs, we can get tolerance. Tolerance is a physiological change. We talked about that. But that physiological change really can get back to homeostasis relatively quickly, a couple weeks or so. But the mesotelencephalic dopamine system doesn't show a decrease in activity because of the drug. It shows an increase, a sensitization, a sensitivity to the drug and the stimuli preceding the drug. You can also get cross-sensitization to other drugs. So somebody might get addicted to one drug, producing those motivation properties, but they can also have problems with addiction with other drugs. We have a cross-modal addiction. The dose required to self-administer methamphetamine decreased in rats. In other words, you need less and less of the drug to get the motivating properties, the craving from the drug, to get the action from the drug. It takes less and less. So, a study was done where a single injection of amphetamine, cocaine, or morphine induced behavioral sensitization that lasted for weeks or months. What does that mean? Give a rat a little bit of these drugs, and we have an sensitization that increases that motivation to press levers or do whatever to get that drug that can last for a long time. It can be true for the incentive motivational properties as well. That action. And keep in mind, though, there is variation within rat populations, there's variation within human populations about how those drugs affect that motivation system. This is something I want to really get clear here. I want you to move away from the notion that drug taking is induced by a pleasurable event, that it's liking the drug. It is wanting and craving the drug. These are impulses. These are invasive thoughts. These are things that twist around in people's heads. This is that mesotelencephalic dopamine system, which is the subconscious whispering to the conscious, telling it what to do. So what initiates these cravings? What we find is cravings are highest not while they're taking the drugs, but just before it. Just anticipatory, okay? And you've seen this before. Imagine your favorite food, chocolate cake or Kentucky Fried Chicken. Just before you eat it, try to bring it to your mouth and then don't eat it. Try to take a delicious thing of chocolate, bring it to your mouth, and then don't eat it and put it away. Boy, you will be thinking about it a lot. It'll be that motivation system happens just before. So when people see the stimuli associated with the drug, an alcohol bottle, needles, mirrors, pipes, whatever, that motivation system really kicks in. For a long time, I had an addiction to Coca-Cola. I don't know if it was an addiction, but I drank more than I wanted to drink, and I had to drink it every day. I had to have a Coke in the morning and a Coke at night. This came from working in restaurants a long time, but what I found was that if I hadn't had it during the day, I really wasn't thinking about it until I passed by a Pepsi machine, till I got home and I saw a can. That started inducing me thinking about it and wanting it. I haven't had Coca-Cola for about 1.5 years, so it's pretty good, and I don't find those cravings anymore. But when I first stopped drinking it, for several months, I'd be in the store, I'd be walking along, fine, I'd pass by Coca-Cola, and then I'd want it, and then I'd think about it. That's just Coca-Cola. That's just a sugary drink. Imagine what that would be for cocaine or methamphetamine, that overpowering sense. Doesn't have to be a pleasurable thing. It can have those qualities or those incentive qualities, but that isn't the main culprit for addiction. So people see these things, and they induce through psychological events, through classical conditioning, instrumental conditioning, they induce those things. For some people who are trying to quit smoking, the worst thing you can do if you're a friend of somebody who's trying to quit smoking is to smoke around them. They see it. They see those things. They start wanting it. They start rationalizing getting it. People get out of a week-long rehab. They've done very little for their addiction. They've dealt with their physiological need for that drug. They're not jonesing anymore. But what happens when they get back into those environments, around those friends, at those bars? Okay, we get those invasive thoughts going on. So, this is basic subconscious learning, but is highly motivating. Classical conditioning, for example, the environmental cues are associated with the drug, the environmental stimuli, the bottle, whatever, and you get sometimes drug-like responses, but you also get the motivating property as a conditioned response as well. So, as an example, put an animal in a cage, give them amphetamine. Cage, amphetamine, cage is the CS, amphetamine is the US, it produces the behavior. But the cage alone can produce hyperactivity, locomotor hyperactivity in animals. Sometimes you can get a conditioned response. So the conditioned response can look like the drug, and sometimes they can counteract the drug effect in a conditioned compensatory response, but you can also get a conditioned motivational properties of the drug as well. So here's a study by Robinson. Cocaine users in phase 1, they took baseline physiological responses, autonomic responses, heart rate, galvanic skin response, those kinds of things. Then they showed the patients who were cocaine abusers, they watched videos of cocaine use, of patients preparing cocaine, the patients prepared cocaine, fake cocaine. They were going through the actions. They hadn't taken the drug at all, but they're measuring these conditioned responses. And a control group just watched non-cocaine related videos or played video games. I don't know what a non-cocaine related video is, but I imagine it's, maybe a cartoon or something like that. And then they were measuring their autonomic responses. And so what you see here is when they watch drug videos, we see electrodermal and heart rate responses, skin temperature, electrodermal stuff decrease at compensatory, but heart rate increased. Condition response that's similar. Somebody takes cocaine, their heart rate goes up. See stimuli that associate with that, and the heart rate goes up. These are physiological responses. But these physiological responses can also induce the motivational properties of seeking out and wanting those drugs. And now we're back to instrumental conditioning, stimulus-response association. Again, this is subconscious. This is the subconscious motivating the conscious. So the stimuli that precede the drug, the environment, the needle, the people, bottles, whatever, cause the response, because what follows that response increases dopamine in the nucleus accumbens, which is the reinforcer. These stimuli initiate those behaviors. Those behaviors can be very complex. The stimulus, the needle, the bottle, causing the behavior, the response, that response can be very complex. Getting money to get the drug, seeking out the drug dealer, going to those places, seeking out, getting, and even convincing yourself you're doing the right thing. That's when it gets scary. The mesotelencephalic dopamine system is activated when presented with these stimuli. We know that when we put people in functional MRIs and we look at that part of the brain when they see those stimuli associated with the drug. But you know what's even weirder is somebody can be addicted to gambling. Now they're not taking any drugs at all, but they're addicted to slot machine. Put them in a functional MRI, show them a slot machine, and the mesotelencephalic dopamine system lights up. Okay, really is highly activated. This is Thorndikean. Okay, remember Thorndike? A cat is in a puzzle box. He presses a lever and he gets out. Okay, the stimuli see the lever, press the lever, gets out. The reward is getting the fish. This is see the bottle, drink alcohol, and you get an increase in dopamine levels that strengthens those connections, those stimulus response connections. That's why I'm going through the supermarket and I see a Coca-Cola bottle. I wasn't thinking about it before, but now I am. Now those responses are in my head. So let's just summarize. Many different drugs affect the mesotelencephalic dopamine system, either directly or indirectly. Repeated administration of addictive drugs cause dopamine systems to become hypersensitive. Hypersensitive to the drug. This is why relapse is bad. They haven't had the drug for 6 months. They take a little bit of the drug. I'm talking cigarettes, alcohol, even caffeine. And this area now becomes super activated again. Okay, I don't drink alcohol, just nothing religious. I have a beer now and then, but it's not a motivating property for me. So if I have a beer, I'm not thinking about getting more and more, but somebody who is an alcoholic who hasn't had a drink for 6 months, they have a beer and suddenly that area is just going, oh, you should get some more, you should want more, you should find a reason to get more. And it increases the motivational properties of the drugs. The hypersensitivity is not only to the drug, but to the stimuli associated with the drug. Dopamine increases in the nucleus accumbens when an alcoholic simply looks at a bottle of alcohol. This sensitization is under the control of the conditioned stimuli. This is a learned process. We need to get away from the notion that addiction is all about the drug itself. It's about the learning properties of the drug. The mesotelencephalic dopamine system is involved in drugs and food and sex and all these natural incentives that are extremely important. But for some people, there's not a ceiling effect. This area of the brain can be super hypersensitive. Dopamine antagonists, things that block dopamine, as well as destroying the system, prevents instrumental conditioning for food and drugs, prevents intracranial self-stimulation. So we know this system is highly involved. Incentive sensitization theory assumes that pleasure and craving are separable. So this isn't a pleasurable thing, though probably pleasure and euphoria and hedonic value has a purpose, especially at the beginning of the drug taking. But oftentimes people lose that pleasurable component. The 3 stages of the incentive sensitization theory is you start maybe with a pleasurable thing. A behavior is followed by something pleasurable, the pleasure of cocaine or morphine or whatever. So it might start as a liking, but the liking goes away. Then we get the associations happening. Then we get the associative learning of the incentive. So now we're getting into Thorndikean kind of stuff of that drug. And then these stimuli go beyond the drug and go into the things like the sight of food for a hungry person, or the sight of a bottle for an alcoholic, or the sight of a slot machine for a gambling addict. Now we have a long-lasting learning process that is very difficult to extinguish and continues to motivate that behavior for a very long time. All of them, all three psychological processes are governed by different neurological systems. But they all play that role. We're finally getting into 2 and 3, we're really getting into the mesotelencephalic dopamine system. But there's also positive addictions as well. In a way, these are really working in the same systems. For example, people who exercise a lot, and they have to exercise every day, or they run a lot. You're going to increase opioids. When you exercise, you're going to increase things that are going to reduce pain, analgesics. It's a natural process. Running hurts your knees, so you're going to produce those things. But you can also increase dopamine by this action. It also increases stress hormones. And what you should also know, this is very important, is that hormones like cortisol, this is corticotrophic releasing hormone, it releases cortisol under stress, makes the nucleus accumbens hypersensitive. It's one of the reasons that people tend to relapse when they are stressed. When they are stressed, the nucleus accumbens becomes hypersensitive because cortisol helps it to become hypersensitive. Okay, so people talk about the runner's high. I like to run. I run off and on, and run some marathons. I'm not sure if I've ever felt that runner's high, but there has been times when I've run a lot and feel like if I don't run one day, I start going through withdrawals. I start getting antsy. I start thinking about running a lot. So reducing the euphoric effect of exercise, people sometimes have to increase the amount of exercise to get that same runner's high, and we have that same kind of thing going on. And people can go through withdrawals. Maybe you've experienced this. You exercised a whole bunch for months and then you stopped. I know this happens after I run marathons. You practice and you're running and you're running and you run a marathon and you're exhausted the next day. You don't want to run for a few days. Your legs are too sore, but you start getting a little irritable. And then gambling. These are the same processes. I'm not sure if I want to differentiate between cocaine addiction and gambling addiction. We know that the same processes are involved. And, about 1% of the population have a pathological gambling problem. We have casinos all around here. People spend a great deal of time doing that. Gambling stimuli can prime the craving. Dopamine levels increase. We also know, this is weird, that naloxone can also reduce the symptoms of pathological gambling. Here's another interesting thing. People with Parkinson's disease have low levels of dopamine in a system from the nucleus, from the substantia nigra to the striatum. Not that important, but what do you do to help those people? You give them dopamine agonists. You help them with dopamine. But about 10% of people who take these dopamine agonists suddenly have problems with gambling. They didn't used to, but they do now. It's all the same kind of a system. Keep in mind, addiction is less about the chemical and more about the behavior. One other example. If I take a rat and he presses a lever and he gets cocaine, he will press that lever. He will press that lever and get addicted to it. However, if I inject a rat with cocaine, he doesn't do anything to do it. There's no behavior. There's no pressing a lever. I just inject him. He doesn't have the addiction to cocaine. The behavior, the learning, these are the processes that deal with addiction. And these are the processes that have to be mediated to reduce addiction. You don't just have them go through withdrawal. That does very little for the addiction.